Hey, Peds crew, welcome back to the deep dive. Today, we're really digging into something fundamental, especially if you work with kids and families in healthcare settings. We're tackling family communication, family dynamics, basically how families talk, what stresses them out, and, super importantly, how you as a nurse can understand and support them better.
Exactly. We've pulled some key stuff from a text that focuses right on this topic in nursing. It covers, well, everything from basic communication patterns to different family shapes, the pressures they're under, and even specific strategies for talking with different age groups, kids, and parents.
Right. So, our mission here is to kind of boil this down for you, give you the essential, actionable insights from this material, tailored for nursing practice, without you having to read the whole textbook. Let's start with the basics. What exactly is communication in a family context?
Okay, so the sources frame it as this two-way exchange. It's not just words, right? It's behaviors, symbols, even like mannerisms, and crucially, the way a family communicates. That tells you a lot about their style, their structure, their relationships. Functional communication, it builds trust, but dysfunctional patterns, they can really chip away at self-esteem.
Wow. Okay. So it's not just what's said, but how. That's huge. And culture plays a big role here, right? The sources stress being culturally aware to avoid bias.
Absolutely. Culture heavily influences how people communicate. It's
Yes.
fundamental. Oh, and another key thing for nurses, a child who's sick or in the hospital, they might not communicate at their usual developmental level. That's important to notice.
Yeah, good point. Okay, the sources outline some really interesting communication patterns. Can you walk us through those?
Sure. Think of them as like different ways families talk. Four main types. The best one is clear and direct. Message is clear, go straight to the right person. Like the example, I'm irritated you didn't put the dishes away as asked. Simple, direct, no confusion.
Got it. Straightforward. Productive.
Then there's clear and indirect. The message is clear, but it goes to the wrong person. So mom tells dad, I can't stand it when people don't put dishes away. Message is clear, but dad might not be the one leaving the dishes.
Oh, okay. So the message lands, but maybe not where it needs to for change.
Exactly. Then it gets less helpful, masked and direct. The message is vague, unclear, but aimed at the right person or group. Like, it's really annoying when children don't work hard in this family. Ooh, what does work hard mean? It's fuzzy.
That sounds frustrating for everyone.
It can be. And the least productive, masked and indirect. Unclear message, unclear target. Kids are all lazy. Just a vague complaint. The sources say nurses can learn a lot just by observing these patterns in family interactions.
That's a really useful framework, and communication isn't only verbal, right? The nonverbal stuff is massive.
Totally. Verbal is spoken and written words. And the sources emphasize clear, simple language. Avoid jargon. And euphemisms, too, like saying passed on instead of died. That can sometimes create distance. For written stuff like instructions, it needs to be at the family's reading level. Super practical point.
And nonverbal, especially with kids, they pick up on everything.
Oh, absolutely, body language, right. Crossed arms versus an open stance, gestures, even paralanguage, pitch, volume, pauses. The sources make a really strong point that kids are incredibly sensitive to caregiver. Anxiety shown nonverbally. So nurses really need to be mindful to speak slowly, watch their tone, listen actively, show you're engaged.
Empathy comes up too as key to connection. How's that different from sympathy here?
Yeah, good question. Empathy is really understanding someone else's feelings from their shoes. Sympathy. Well, the sources say it isn't considered therapeutic in this context. Responding positively with empathy builds that trust and helps kids develop their own communication skills.
Okay, before we get into stressors, the sources make a point about defining family. It's evolved so much.
It really has. The basic definition they use is just two or more members interacting and depending on each other socially, financially, emotionally.
Yeah, and they give that historical perspective, right? From the 50s, leave it to Beaver, nuclear family idea, to today's diversity, like you see in shows like Modern Family.
Exactly. That nuclear model, married parents, kids, was dominant, but things started shifting dramatically from the 60s onward. Social changes, birth control, divorce rates, lots of factors.
So, what kinds of family structures do nurses commonly see now?
Oh, all sorts. Extended families, grandparents, aunts, uncles living together. Single-parent families, the sources note higher rates for black children, statistically. Blended families, cohabitating families, unmarried parents, same-sex partner families, adoptive families, foster families, even dyad families, which are couples without kids, or communal families. The absolute key takeaway for nurses, stressed in the sources, is don't be judgmental. One structure isn't better than another. What matters is that positive, supportive environment for the child.
Right, it's about supporting the unit that is there, whatever it looks like. Helping them provide the basics, shelter, food, but also love, belonging, teaching how to cope.
Precisely. And families have roles, right?
Mm.
Provider, housekeeper, caregiver, socializer, even the family therapist sometimes, and family dynamics, how they interact. Who's the disciplinarian? How do siblings learn from each other? Sibling rivalry. Even birth order. The sources mention a study suggesting it can influence communication, like firstborns may be more direct, middle kids as mediators, youngest may be more self-centered. Interesting tidbit.
That is interesting. Okay, but families don't exist in bubbles. They face outside pressures, stressors.
A lot of them. The sources list quite a few. Just overwhelming worry about a sick child, obviously. That can lead to neglecting other kids or their own needs. Loss of income, job issues, unemployment, underemployment, insurance problems, being uninsured, underinsured. The sources cite millions affected. Poverty, homelessness, also chronic illness or mental health issues in a family member. Adding new family members, lack of good support systems, cultural or religious constraints sometimes, maybe just not having great coping skills, societal pressures, work demands pulling parents away.
Wow, that's a heavy load before you even add a child's illness. And when a child is sick or hospitalized, that stress just multiplies, right?
Yeah.
Affecting everyone.
Absolutely. The sources list common reactions: disbelief, frustration, anger, denial, anxiety, depression, fear, guilt. It's a roller coaster.
And siblings face their own unique struggles too.
Yeah, definitely. Feeling isolated, scared, sometimes that magical thinking like they caused the illness somehow. Routines get disrupted, school problems might pop up, acting out, jealousy, just a lot of uncertainty for them.
So, faced with all this, what can nurses do? How can we help families cope during hospitalization?
The sources offer practical things. Communicate openly and really listen. Encourage parents to participate in care. Validate their role. Build trust through honesty and just being good at your job, clinically skilled. For chronic conditions, start discharge planning conversations early. And encourage sibling visits, but prepare them. Let them know what to expect. Sights, sounds, smells. Child life specialists are great here.
The nurse's role sounds so central. What are the core strategies for communicating effectively as a nurse?
It starts with introductions. Make sure everyone knows who's who, you, the parents, the family members, and the child. Define the team, and documentation is huge. Especially phone calls note who, when, what advice was given, any questions asked, cover your bases.
And setting the scene for sensitive talks matters too, right?
Totally. Privacy is key, especially with health info. A KaiPad is obviously critical, only share with those who have a direct need to know for that specific care episode. Anticipatory guidance is another big one. Preparing families for what's coming up, tests, procedures, next steps. It reduces stress and builds their competence.
Communication during emergencies must be incredibly difficult. Any specific advice there?
Yes, it's very high pressure. Find a quiet place if you can. Speak slowly. Avoid jargon that's critical. Sit down, eye level. Allow lots of time for questions. Repeat information if needed. And this is a big one. Never give false hope. Be empathetic, be sincere, but be honest. Give clear, concise updates. Don't make promises you can't keep. Tell them when the doctor will speak with them. Provide privacy. Call for support, social work, clergy.
Technology adds another layer these days, doesn't it?
It really does. Smartphones, social media. The sources mention it makes parenting harder in some ways. They even cite concerns about screen time in young kids and potential developmental delays. But tech also connects families to health info and professionals. The challenge is sorting the good info from the bad online. Nurses can help guide parents and teens to reliable sources, like the CDC or Mayo Clinic websites.
So what gets in the way? What are the big barriers to good communication that nurses need to watch out for?
Oh, there's a long list in the sources. Physical things, like a cleft lip affecting speech. Physiological issues, hearing or vision loss. That brings up ADA rights and mandatory inch and hearing screens. Cognitive barriers, like not understanding complex terms or sarcasm. Avoidance language denial, minimizing things. Just plain environmental noise. And a huge one. Cultural differences, not tuning into the family's specific beliefs, values, goals. Language barriers, obviously the Civil Rights Act mandates interpreters. Psychological issues. Biases, either the nurses or the families. Asking only closed-ended yes-no questions instead of open-ended ones. Ignoring the family's psychosocial context. There's even a specific box mentioned, box 3.1, listing things like prejudice about family structures, unaddressed fears, lack of respect, not giving enough info, dismissing minor questions, not treating parents as partners. It's a minefield if you're not careful.
Wow, it really requires constant self-awareness. Okay, so if understanding the family is so key, how do nurses actually assess them? What tools do the sources suggest?
Right. Assessment is foundational. Yeah. Because family resources and processes directly impact the child's health. This means understanding their structure, who's in the family, their socioeconomic status, resources, health history.
And parenting styles come up again here, influencing outcomes?
Yes, three main styles are described. First, authoritarian dictatorial. Very strict rules, low child input, punishment often involves withdrawing approval. Kids might be shy, maybe overly compliant.
Okay, strict.
Second, permissive or laissez-faire. Kids have a lot of control, few rules. They might struggle with boundaries outside the home, could become irresponsible or aggressive.
At the opposite end.
Kind of.
Mm.
And third, authoritative or democratic. This is described as a balance. Firm rules, but open discussion is encouraged. Focus on teaching consequences. Kids tend to be more self-reliant, assertive, higher self-esteem. The source suggests it combines the best of the other two.
That makes sense. A middle ground. So nurses observe this, and roles, relationships, like who does chores, who makes decisions.
Exactly. And there are specific tools mentioned to help structure this assessment. The genogram. It's like a family tree on steroids, maps, relationships, health issues, patterns across generations.
Yeah.
Really insightful.
Cool. What else?
The kinetic family drawing.
Yeah.
You ask the child to draw their family doing something. It can reveal their perspective, who they feel close to, areas of stress.
Ah, through the child's eyes.
Yep. Then structural family assessment interviews, questionnaires about who lives there, demographics, jobs, education, family rituals, and even looking for things like triangulation.
Triangulating.
Yeah, where two members team up against a third, or maybe communicate through a third person instead of directly.
Gotcha.
And functional family assessment, observing interactions,
Yep.
power dynamics, roles, communication styles. This helps develop that cultural sensitivity, seeing how culture shapes interactions. Finally, the family APGR. It's a quick 5-question survey. Measures family members' satisfaction with how the family functions. Adaptation, partnership, growth, affection, resolve. Gives a quick snapshot, often used outpatient or home health.
Those sound like really practical tools. Now, let's shift specifically to communicating with the child. The sources say they shouldn't be excluded, right?
Absolutely not. Even if parents are the main historians or decision makers, the child needs to be involved appropriately. Who talks to the child about what should ideally be a collaborative decision between parents, nurse, and the provider, and how you talk to them?
Yeah.
That totally depends on their age and development.
Okay, let's break down those age-specific strategies, starting with infants.
Right. Infants, birth to 12 months, they can't use words, but man, do they communicate. Crying, cooing, smiling, body tension. They respond hugely to touch, sound, tone of voice. They're learning object permanence things still exist, even if they can't see them. So nurses communicate mainly with parents, but also to the infant. Learn their routines. Use gentle touch. Talk or sing during care. Use pacifiers. Respond quickly to cries. Use stimulation, visual, auditory, touch. Consistent staffing is great, so nurses learn that specific baby's cues.
Makes sense. What about toddlers and preschoolers, 1 to 5 years? They're very different.
Oh yeah. Egocentric world revolves around them. Concrete thinkers, very literal. They explore by touching everything. Medical play is fantastic for this age. Let them handle safe equipment, maybe practice a procedure on a doll. Remember, they take words literally. Stick means a twig. Take your blood pressure. Might sound scary. Bleeding could mean my insides are leaking out.
Wow, need to be careful with language.
Definitely. They fear unfamiliar things, so pre-op tours can help. They talk to themselves a lot. That's normal. So nurses, use simple, concrete terms. Avoid euphemisms, say small poke, not bee sting. Get down on their level. Keep scary stuff out of sight until needed. Use treatment rooms for painful things, not their bed. Help them name feelings. You look scared. Offer simple choices, red or blue bandage. And prepare them right before procedure, not way in advance. Support their pretend play. It helps them process.
Okay, moving up to school-age children, 6 to 12 years, they're getting more logical.
Yeah, more curious. They want to know why and how. They learn by doing. Respond to positive feedback. Might try to bargain. Still concrete thinkers mostly, but can link new info to things they already know. Nurses should treat them like part of the team. Give them small jobs if appropriate. Explain the why and how simply and honestly. Still avoid super abstract stuff. Let them participate safely. Maybe help take off a bandage. Let them ask questions, voice concerns, and make sure they have time for play and fun. Older kids in this group might benefit from journaling or peer support groups.
Good tips. And finally, adolescents. 13 to 18 years. A whole different ballgame.
Totally. Independence is huge. Peers are everything. Behavior can swing wildly. Trust is essential. They have their own language, their own culture almost. Decisions might be more influenced by friends than family sometimes. So nurses, use open-ended questions. Encourage them to talk about their feelings. Provide privacy. They might not be honest with parents there. Explain the limits of confidentiality clearly up front. Help navigate disagreements between teen and parent viewpoints. Build rapport through being genuine, trustworthy, listening, showing respect. And a really key reminder from the sources: don't confuse physical maturity with emotional maturity. They might look grown up, but still process things differently.
That's a critical point. The sources also touch on some really tough family situations, right? Like substance abuse or illness.
Yeah, communicating with what they term altered family units facing crises. Things like substance abuse, where you might see those family roles emerge. The enabler, hero, scapegoat, lost child, mascot. Secrets are common. They mention coercive processes, criticism, inconsistent punishment, and abuse: physical, emotional, sexual, with the huge caveat that nurses have a legal duty to report suspected abuse.
Absolutely non-negotiable.
Right. Then there's navigating chronic physical or mental illness. Nurses educate, support adherence, ensure follow-up, connect families to resources like Medicaid or respite care via social work. Hospitalization itself is a crisis needing adaptation, and communicating around death in the family. Responses vary so much by age and grief stage. Oh, and legal stuff like custody, power of attorney becomes really important to clarify for non-traditional families right at admission.
The sources also bring up various theories: family systems theory, developmental theory. We don't need the deep academic dive, but why do these matter for a practicing nurse?
Think of them as like different lenses to understand why families function the way they do. They provide frameworks. Bowen's ideas about triangulation, Duval's stages based on the oldest child's age, Newman's focus on stress and prevention. They help explain patterns, assess needs more deeply, and plan care that actually fits the family situation. They give structure to your observations.
So they help make sense of the complexity, and they lead into a core philosophy mentioned throughout: family-centered care.
Exactly. It's not just a buzzword. It's a philosophy that says kids get the best care when providers truly partner with parents and families, recognizing families as the experts on their child, respecting their diversity, their values, their coping mechanisms.
And there are real benefits to this approach.
Definitely. For the child, less anxiety, maybe less need for pain meds, better coping overall for the family, feeling empowered, less stress because they're included in decisions and care. Nurses facilitate this by encouraging rooming in, making space for quality family time, actively supporting parents in their caregiving role, being aware of separation anxiety, especially in toddlers, and involving parents appropriately in procedures. That's all part of it.
This has been a fantastic deep dive. It really highlights how interconnected everything is: communication patterns, family structures, stressors, age-specific approaches, assessment. It all comes together in providing that truly holistic, quality care.
It really underscores that the family isn't just visiting. They're absolutely central to the child's health journey. Understanding them is non-negotiable for good nursing care.
Absolutely. So here's a thought to leave you all with. Given the incredible diversity and the constant challenges families face today, how can nurses continue to adapt their communication and approach to ensure every single child and family feels truly seen, heard, and supported?
Families matter. Let's care smarter.